Hello, everyone, and welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I am Grace Pratt, the production editor of the podcast, and I'm joined by three of our co-hosts today. And we have a topic who we were just joking, I'm sure no one cares about because no one sees ever in primary care. Please listen to the sarcasm in my voice. We're going to talk about trauma, which I thought for sure we've discussed. It's a huge passion area of mine. It's something I care deeply about teaching and working with our residents, with my behavioral health students, with my patients. And yet, as always seems to happen to me, I think, oh, we've definitely covered this, and it's not there. So we're going to do it today. But first, we're going to start the way we always do with our icebreaker question, going around the table. And I'm curious to hear, because this is something that's been coming up lately just among our residents, and it's something I've been enjoying chatting about, is tell us about your first car. So moving around the table, actually want to highlight that this co-host has been with us for 1 year now. I can tell by the look on your face that you didn't realize how much time had passed, but we are so lucky and happy to have Jen Thomas.
Hey, 1 year. Wow, that flew. That's crazy. That's awesome. Great. Yes. No, I'm Jen Thomas, family medicine, doing a little addiction medicine, medical director of integrated behavioral health at Morris Hospital in Morris, Illinois. My first car was a lovely hand-me-down maroon Dodge Aries, probably like a 1992. It was my dad's old car that, was bumped down to me and my older sister. It was great. It was definitely, a clunker, and it got the job done though. It didn't have working AC, but it got you to school and back. So it was fun. We shared it, but we made it work. So yeah, the good old Dodge Aries. Well, dates me, I think, but it works. Got the job done.
I love it. Wheels from point A to point B, which when you're in high school, that's like the primary.
That's all you need.
Right?
Correct.
I love it. Next, we have Neftali Serrano.
Hey, everybody. My name is Neftali Serrano. I am the CEO here at the Collaborative Family Healthcare Association. Happy to be back here on the podcast with you all. All right. So first car, I'm not exactly sure of the year, but it was somewhere around a 1986 model. So that dates me and the car because the car was already old when I was driving it. And it was, my dad is an auto mechanic, retired auto mechanic now, but
Cool.
And so we always grew up with like old cars that he would fix up. So this was one of those kind of cars. He bought it for me. He fixed it up for me. It was a black Mercury Cougar, so it's a model that doesn't even exist anymore. But it was a nice smooth ride. It's the car that I actually eventually got married in, because one of my last memories of it was driving away from the wedding with my wife in it, with the cans trailing in the back.
Cool.
This was in driving from Madison, Wisconsin to Door County, Wisconsin, for those of you out there who know the territory. On another podcast, I'll tell you the ill-fated story of the honeymoon that was pretty bad. But driving away, it felt good in the Mercury Cougar.
Oh no, I'm curious about the honeymoon, but another day.
Yeah. Oh, okay. I'm feeling an August icebreaker. Tell us about some of your worst vacation memories.
Oh, that's a doozies.
I feel like that's going to be up there
next time.
Thank you, Neftali. And next we have Bridget Beachy.
Hi, I'm Bridget Beachy. I'm a licensed psychologist by trade, work as a BHC and in leadership, and also do consulting work. As far as my first car, it's kind of funny. I loved my first car. It was a red 1996 Grand Am, Pontiac Grand Am, and it was a great vehicle. And so I got it before I turned 16. So I have one of those. Technically, it's considered summer still. So, my birthday is September 19th. So I'm like I'm turning, it would have been I was 15 turning 16 my junior year. So, then you graduate high school when you're 17.
Yeah.
You go to college, you're 17, and then you
Yep.
turn 18.
Mhm.
So all of my friends, like had their license or whatever. So my parents got me the car in the summer when I still like had my permit. So I got my license like 10 days after I turned 16, based upon whenever we could go, as soon as possible. And I probably shouldn't be admitting this, but my friends and I used to kind of take the car out before I had my license and drive it a little bit. And we also named it a Hester, from Hester Prynne in the Scarlet Letter, because it's red.
Love it.
And we were reading that in school at the time. So we named her Hester, and I love that car.
I feel
Fantastic.
safe to say that any statute of limitations has passed. Like,
Yep.
you're good.
Yep.
Yeah,
Yep.
should be fine, right?
Oh yeah.
Oh, that's funny. And
Never
like I
got
said, no, go ahead.
Never got caught. So it's all
That's the bragging point. Like I said, I'm Grace Pratt. I am the behavioral medicine faculty at a community-based family medicine program in Oklahoma City, Oklahoma. I'm a licensed marriage and family therapist. And my first car was this really cute 1998 Toyota Corolla. It had a little spoiler on the back. And I drove it for 10 years. And I usually say that by the end, it had a stroke because everything on the passenger side worked great. The power windows, the locks, like everything. But on the driver's side, first the locks stopped working, and then the windows stopped working, and like all the paint started chipping off. So that car served me well for a long time, but it was definitely got as much use of it as it had. Well, that's fun. Thank you all for sharing that. Like I said, our main show topic is about to be about trauma, and we also have an exciting special segment to share later in the episode. But for now, are there any news and notes, Neftali?
Yes, actually, we have two things here on the news and notes. One is some super exciting news in the world of integrated care. So an organization called the Health Federation of Philadelphia, to my knowledge, it's the largest basically training group, cross-organization training group for primary care behavioral health. So this is an organization that basically convenes behavioral health consultants from, I think it's over 24 organizations across the city of Philadelphia. And I forget at last count how many people that includes, but it's, I think, over 70, 80 behavioral health consultants who regularly meet. I think it's about twice a month, and I've been meeting twice a month for training in the city of Philadelphia. Now, you may think, well, what's exciting about that? Well, the exciting thing is not only is it unusual for that sort of thing to happen. Again, this is not the same organization. These are federally qualified health centers, private hospital systems, city clinics, all sorts of HIV clinics, all sorts of different clinics sending their BHCs together to be trained in PCBH. What's exciting about it is that the city of Philadelphia thinks this is so important to the infrastructure of their healthcare in their city that they have a line item in their budget for the director of this training consortium. And to my knowledge, it's the first of its kind where you have a city, it's both a city and a county, they're the same thing, investing in integrated care in this particular fashion where it's part of the city budget.
Wow.
That's pretty amazing stuff.
Crazy.
And, certainly we hope that that's just a model that helps, again, across organizations. So we're not doing one at a time type implementation where we really have a model that's a lot more scalable than trying to have every institution replicate a whole new training environment. So kudos out there to the Health Federation of Philadelphia, hfp.org. If you want to look it up, we'll put the link to the press release in the show notes. And kudos to Natalie Lefkovich, who has really been championing this in the city for over, much more than a decade at this point, and did a lot of work behind the scenes to make this case for integrated care. So super
Hold on,
awesome.
spoiler alert. I'm speaking with Natalie this afternoon, and that will be our special segment at the end of the episode. So keep listening, and we'll have more details about that collaboration.
That's awesome. That's awesome. So, yeah. And the other news to note is, not surprisingly, our annual conference, Phoenix, Arizona. I know that all you're hearing right now, if you're listening to this within the next month or so, is that Phoenix is sweltering hot. And yes, Phoenix will be warm-ish, hot-ish in October, but it'll be a lot less hot. So it'll be a nice time of year to come hang with a community of folks that really cares about transforming the healthcare system. If you're passionate about all those things related to making life workable for you as a healthcare professional, building your care teams, learning about the prevailing models, COCM, PCBH, SBIRT, MAT, learning about social determinants of health, everything you can think of, this is a Disneyland for integrated care. So go to integratedcareconference.com. That's integratedcareconference.com for more information for our fall conference in Phoenix.
Awesome. Well, we are excited that we are going to be able to have a recurrence of our live show at the conference. We will be live on stage again. And so we hope that our listeners will, come hear us. And I know that we had a lot of people that started listening after we recorded live last year. And we've been thankful to have you stick around. So I'm going to transition us into our main show topic. Like I said, trauma and trauma treatment is a real passion area of mine. And in fact, when I'm teaching, a lot of times I tell students, I'm a therapist who's working with physicians who have to make decisions all the time that are like literally life or death. You can prescribe this medication to someone, and if you do it wrong, they could die. And I think there's not a lot of things that have that level of acuity for us as therapists, in some ways. So I'll give a lot of caveats, but even like a so-so therapist, there's an opportunity cost of not helping someone in the way that they need to be helped and how they could be improving. But as long as you're basically ethical, I think you're usually not going to like damage a patient or cause like deeply lasting harm. And we can argue that if we need to, but a huge exception is trauma treatment and addressing trauma. And if we go about it the wrong way, and if we do not, practice in a really trauma-informed way, we can have someone be much worse off when they leave us than they were when they came in. And so to me, the gravity of how we're addressing and treating trauma needs to be at the forefront of everything that we're learning as this interdisciplinary group of clinicians that we represent in CFHA, whether we're talking about physicians or BHCs or community health workers or all of the many different types of clinicians that are represented in our team, even leadership, because trauma-informed care is as much about organizational principles as it is about the direct clinical delivery. You don't have to say through worldview, but like through worldview. So I want to open it up to us. And Neftali sarcastically, before we started recording, was like, nobody sees trauma in primary care. But I do want to say, like, broadly, what does this look like? How do we see, or when, or how frequently, how is it coming up that we're treating patients with trauma and PTSD in primary care?
Every day.
Yeah. It's funny to ask that question, because it's almost like, when are we not interacting with some form of trauma, right? We may not be interacting with formal PTSD, right? But we're often interacting with trauma on some level, right? And it may not even be direct, but it's just a part of the picture. It's part of the context that we, have in mind as we're working with someone. I think what you're obviously getting at is when trauma is more the the acute concern or the main triggering factor, right? Those are situations that a lot of clinicians start getting anxious about, I guess. Maybe even I would say triggered sometimes. Sometimes because of a lack of understanding, I think, of what it means to work with patients with trauma. And I think, you started alluding to it, that a lot of what working with trauma is working from a trauma-informed perspective. It doesn't mean whipping out every time you hear the word that some patient is engaging in trauma. It doesn't mean that you're whipping out, PTSD treatment protocols right off the bat, right? But it does mean that you have an understanding of the role that trauma can play in someone's functioning. It becomes a part of their context, and you use that context to inform how you're going to, help them continue to make changes in their life that are healthy, help them to learn how to engage that trauma in an effective way. What I have found cool about working with trauma, I actually really enjoy working with trauma. I think, like, I sense you do, Grace. There's something special about working with patients in that space of their life. And there is an amazing amount that you can get accomplished in a medical center, right? In other words, in a center that's oriented around primary care, for example. I actually think I have an advantage compared to my colleagues in specialty mental health. In part because trauma is necessary to treat the whole person. You have all these physical symptoms that are often at play, and then you have a physician who, when they do their job well, when they have a trauma-informed perspective, when they are caring and kind, understanding, when they can do a good physical exam and address the somatic concerns and complaints, obviously prescribed medication is necessary, they create that environment. Then I get to come in under that existing safety that the patient has with their primary care provider. And it's almost like, I'm set up. If I do the right thing, if I understand context, if I really get this person, boy, I've seen some patients' lives changed dramatically by the space that we create as a team. It's been some of the most satisfying work I've done.
Bridget, I need you to say out loud some of these gems that you're putting in the chat, because oh no, sound problems. So let me add on what you said, Neftali. I think it's so deeply pervasive. And one of the things that's really interesting to me is that it's a both and a recursive process. So if we're thinking about like how it comes in and how it presents in primary care, first of all, we know from so many classic studies about the ACEs, like how prevalent potentially traumatizing events are. And we also understand now that trauma reactions, trauma perspective, and the impact of trauma is much more of a continuum than a binary. It's not like either you have PTSD or you don't. You're traumatized or you're not. Like, that is just not how it works. And it's a recursive. So we see patients who have trauma because of their medical experiences and healthcare difficulties as a whole other layer of people who come in with this existing context of trauma. And so there's so many pathways that this can happen, and it compounds. So someone maybe because of the contextual potentially traumatic events that they've experienced in the past is more vulnerable to experiencing marginalization, discrimination, like direct traumatization that can happen. And sometimes that presents as like, I have had a trauma, flashing red light. And sometimes it's like, I feel bad. And there's a lot of bad things happening in my body. I can't sleep a lot of time. So in my clinical experience, I don't have a study to point to about this, but a lot of time, some people do come in and name their trauma and they recognize that they're traumatized. But for many of the patients who don't, or maybe haven't built that bridge yet or made that connection, a lot of times it's sleep that's the first kind of toe in the door for me to recognize like there's something else going on here. Okay, Bridget's audio is back. Tell us, Bridget, say these wonderful things that you're putting in the chat.
Was that the prompt? I didn't even hear what you said. I couldn't hear anything.
Yes. I said, I need you to say some of these things out loud.
Yeah, the contextual interview changed everything for me, which is no surprise to any of our listeners. But the amount of folks that reveal trauma and the whole range of it on the very first time of meeting them has soared through the roof with doing that. I worked an entire year not doing the contextual interview, actually about a year and a half as a BHC, doing the 5 A's. And then I learned how to do the contextual interview. And I'm not here to like argue, folks, do what you got to do. But I was a clinician doing 5 A's for 18 months. And I've been a clinician now for 8.5 years doing the contextual interview, and I will never, ever go back. The things that folks tell me when I'm genuinely curious in their life, and it does not take long. And you get right to it. And the way I look at it is, it's easy for me to work with a patient who has trauma versus putting that type of pressure that I have to work with trauma. So I don't look at it as I'm working with trauma ever. I always look at it, I'm working with the patient and they happen to have trauma. And it's at varying levels of what we might need not even talk about it. But like, as Neftali was saying, that's in the context. So now I know that's an experience that they've gone through. And it's so interesting being like really calm as a clinician, knowing that we don't have to talk about it, or we could talk about it or whatever, the amount of things that people then will tell me. And I'm not using it as like a trick. I'm not trying to say like, oh, you don't need to tell me. And then that gets them to tell me. I really, truly don't care if we talk about it or not. Meaning as a clinician, I think that we can move forward, whether or not we address the trauma specifically or not. We can talk about their life. And what will happen is when I stay really, really calm, I'm like, listen, we can talk about it or not. I think we can make movement, whatever way we want to go, whatever we want to focus on. And it's so interesting, within like 60 seconds, often, maybe even less, they're like, actually, I do want to tell you about that. And then we might not even have that be the focus of our quote unquote treatment moving forward. It might just be in the contextual lens. And now that helps me understand where the patient's coming from into their milieu. And we might talk about something completely different. So I think that when we as clinicians get really freaked out about like, do we do trauma and PCBH or not? I think we're asking all the wrong questions. I think the question is, can you help a patient who's had trauma in the primary care setting? And the answer to that is a resounding 100,000,000%.
Which that's the lens change, right? That's going from thinking about primary care and specialty care as these like deeply, like specific problem specific, oh, this thing can only be treated in primary care. This thing can only be treated in specialty care. And like this person has to have EMDR, has to have like deep, months of narrative work and reprocessing therapy. And maybe that person would benefit from that. But it takes a really specific person to be ready to go do that kind of treatment. It takes a time availability. It takes a safety and stability in their life. And, one of my favorite trauma treatment theorist is Judith Herman, and she does a ton of discussion of narrative reprocessing therapy and like reconstructing all of those underlying core beliefs that are impacted by trauma. But what she emphasizes is a 3-phase model of trauma treatment. And the first phase is safety. And what I tell my learners all the time, because my learners are like, well, I have to be doing that work to be doing trauma treatment. I have to be like getting into the narrative. We have to be talking about the details and doing this like reprocessing. Like, okay, that's trauma treatment, but safety is also trauma treatment. Safety is not the thing we get out of the way to get to the real trauma treatment. Helping someone to feel safe in their body, to stabilize their medical treatment, to have their social needs met, to have a rapport with their clinicians, with their physicians, to be safe in their own body. And one thing I was noticing when you were talking, Bridget, and you didn't say this, but it's a clinical pearl that it prompted for me that I wanted to make sure to share with our listeners, is it's okay for patients to share their trauma with us quickly. What we want to watch for, and where I think clinicians get in trouble, and especially new BHCs or people who aren't versed in trauma treatment, is letting someone dump all the details of their trauma and get into this like really nitty gritty re-experiencing in the moment before they have the tools, before they have the safety, because that can be really problematic for people when they go deep into the details of their trauma before they're ready and before it's clinically indicated. And so what can happen is then they feel gross and they leave and they're not in a good place with that and they weren't ready for that. And then they associate you and treatment with like this gross, dysregulated feeling. And so we can let someone and need to let someone hold space for their trauma as they're discussing things that have happened to them in their context and their past. But we need to be ready as clinicians to say, oh my gosh, thank you so much for telling me this. This makes so much sense in the bigger picture of your health and your personhood and your life. And I want to slow you down from feeling like you have to tell me every detail. And we have to say it. It's a trick because we have to say it in a way that doesn't sound like we're saying that's too much. I can't handle that. There's not a place for your trauma here. And at the same time, we need to recognize that a lot of the clinician's job, especially in that safety phase of treatment, is helping the patient regulate, helping them to slow down and to be safe, even in their body and in their story as they're addressing their trauma. That's a big soapbox for me. That's like a little bit of a departure from this conversation, but it's a clinical pearl that I feel like is one of the most important things that we can tell people, because I agree with you that there are clinicians and there are BHCs and there are physicians too, who are like really scared of trauma and scared of what a patient's going to come out with and how they're going to react, because it feels like trauma is this really big thing that I have to spend hours on, and this person needs like months of intensive treatment. And like maybe, but safety building is trauma treatment in itself.
And I
So
think that's just like,
Go ahead.
just wanted to add on about what you were saying about like that they think of what they need. We got to remember the patient, say they're 60 years old and they went through that and they've never talked about it. The amount of time, if I had $1 for every time somebody said to me, I've never told anybody this, and they tell me it, they live for 60 years with it. Like, let's not be scared, clinician. I mean, Grace, I agree with you. Like, don't let somebody go into the nitty gritty and then just like, they're all completely dysregulated. But
and then we're like, bye, it's been 15 minutes. That's not what we're doing here.
That's not what we're doing. If you do this thing right and you stay curious and you're completely connected and locked in with this person, I've never had that happen in 10 years of seeing 2,500 patients. I've never had that like happen. I don't think we should be scared as clinicians of trauma and getting to the point where it's like, oh, this patient needs X and they need Y and they need Z and they need this. Remember, they are strong. They are resilient. They've lived 60 years. They've lived 15 years. They lived however many years with that trauma. Mm-hmm. And so, let's not tell them what they need.
Yeah. Yeah.
And, I think there's a superpower we have that I think those of us in this room take for granted. And again, I'm just going to point back to this, is I think it is such a huge superpower. It is the setting and it's our partnership as a team. And Jen, I wanted to ask you about this because I've worked with some great physicians and PAs and NPs in my time. And I am so impressed because a lot of these folks I've realized over time have very little training.
Yes.
With trauma. These folks have such great relationship building skills that, again, like I can't say this enough. The advantage that I go into an exam room is huge. I've got a huge head start in working with a patient with trauma because of what the physician has done in setting up that safe relational environment to begin with. And I've experienced on a few occasions the opposite of that, where maybe a physician was not terribly effective at establishing a safe place, but that's more the exception. So can you tell me a little bit about like how that works for a physician when you're dealing with a patient experiencing some form or have had some experience of trauma? I mean, how do you do that when you have like
That's such a good question. I've been sitting here thinking, like, I can't wait to ask you guys, how do I do that? Please teach me how to do that. And I think that comes from a bit of imposter syndrome, or a bit of the, I haven't had formal training. When you started talking about trauma-informed care, I'm like, have I had that? And I like think back to residency. I'm 13 years out. I'm like, I don't think I had any formal trauma training sessions at all in residency. I'm sure that's different nowadays. Again, it's 13 years later. I went to a trauma-informed care seminar like 4 or 5 years ago at our county health department. It was awesome. I was the only physician there. So I would guess that my peers and my medical group have had zero. And maybe they love that stuff and they're learning it and reading on their own time. And that's fantastic. I hope they are. But my suspicion is that I am not alone. When you would poll docs and like, what are you trained in trauma? Do you know how to deal with trauma? Heck no. Do we probably do better than we think at setting up patient relationship, rapport, safety? Yes. I think that's probably the secret sauce. Why do people tell me the thing that they've never told anyone? Probably because I've gotten to know them. They live in my town where I work. We've seen each other for over 10 years. So we develop relationship. And so I don't know. It's fascinating that, like, I don't know the answer to that. I think it's probably something we might do in primary care as clinicians and not even realize we do. But man, you talk about harm, and I'm like, I do feel the pull of like, I want to hear your story and I want you to have a safe space to talk about trauma. But I got 3 patients in waiting rooms waiting. What do I do? Right? Like, I could bring Mike in. He's my COCM care manager, but that's not always available. So like, how do you teach and I'm one of these, I'm a new learner on talking about trauma. What would you say to a PCP of like, here's how you do it well. Here's how you talk about trauma as a medical clinician, utilizing your teammates, of course, but in a good way, in a way that's not damaging, that keeps the door open. I don't know if I do that right. So I'm curious what you tell me to do. So I'm all ears.
I hear this a lot, and I heard it echoed in what you said from my learners, who, when they start to recognize, well, I'm going to just totally steal your words, what you just said in the chat, Bridget, again, that it's more common to have trauma than to not. So when they start to recognize how pervasive it is, and, trauma cuts across every demographic. And certainly there are particular groups who have more historical trauma or who are marginalized in certain ways and experienced discrimination and specific like racism and sexism and other xenophobia. And like there are traumas that are specific to groups, but trauma also cuts across groups. And I think when we recognize that, it doesn't matter where in the country you're practicing, it doesn't matter the demographics of your patient population, there is likely to be trauma. And so I think, first of all, recognizing that you're doing it, you are treating patients with trauma, and holding space for that and recognizing that and being open to understanding that that part of the context might be part of what's going on for someone is a key piece of it. But then what I have my learners say to me is like, what can I possibly do? Like when I start listening to this patient's story and listening to all the things that they've been through, and medically they're fine, which sometimes they're not, sometimes it's that someone's coming in with all kinds of things, but a lot of times, even for patients who are having a more physical manifestation of their trauma symptoms, there's not an organic cause to what's going on. So it might look like a somatic presentation, or it might look like these non-specific aches and pains, and you check everything out and there's not a specific something that you can prescribe. That's one of the hardest things as a physician, is my perception and what I hear from my residents, is when you come to the end of the tools that you have to offer and you can't prescribe something that's going to fix this, and you can't take away what has happened to someone. And what I say to them is that you are doing it, that human connection of sitting with someone and recognizing that light within them and being a person who cares about them and hears what they've been through, and also kind of tend to, what we are going to look into and see if there's an organic cause to what's going on. We are going to think about how your sleep is fitting into the bigger picture of your health, or we are going to be connected in our community and be, again, you said superpower, Neftali, like our integrated teams are extremely equipped to address, because trauma is a whole person problem, and we are teams that are committed to supporting whole person health and wellness. And so like you are doing it, and where you feel like you have a limitation, oh my gosh, all I can do is listen to this person. All you can do is listen. Like, please don't undervalue and underestimate the gift that is to someone that's sitting across the room from you.
And Jen, if people are telling you the same thing, that they've never told anybody this, and they're telling you it, I agree with Grace that you're already doing it, because they feel safe enough to tell you what's up. They feel safe enough to tell you what's happening. Now you have the superpower of the contextual piece of understanding maybe what they've gone through, and you just being sorry for my language here, but being a fucking human with them.
Yes.
Being curious, not trying to treat them. Y'all, like, that's what I get crazy on this one. It's like somebody tells you trauma, it's like, we got to get you to therapist, and we got to get you this, and we got to get you that.
Yeah.
What kind of message is that? Like, if you went through something, right, and there was somebody you trust in healthcare, you finally you haven't told somebody in years, maybe never, you tell them, and they start talking about how they got to get you elsewhere. I hear that in PCBH. Well, we can't do trauma in PCBH. We can't do it. What? That's more harm. I think the most harmful thing you could do to somebody is they reveal their trauma, and you figure out all the ways in which you're not going to see them.
Yeah. Yes.
Yeah. And I think we pathologize it. I know we do in like allopathic medical school training. We're a fix-it profession. It's almost algorithmic, right? Like, here are your symptoms. Here's your diagnosis. Here's the plan. Throw Pratt at it. If you have
CBT,
trauma,
it's always CBT,
right? Pick the right, answer. And there's no human connection part of it. That's been my biggest, I think, aha moment, integrated care learning journey for me personally, is unlearning some of that it's not a pick the right pill, Jen. It might be sitting with you and listening is how I'm helping you. I'll be darned. That's amazing. And that feels really cool. That feels like another tool in the toolkit, right? It's not like you're just stuck if the pills aren't working. Yes.
I think it's empowering to recognize. And I also think trauma is something, like, we keep saying how alarmist we get. I love that you said pathologizing, or Jen, you're like, people do try to slice this out as the thing we can't do in primary care. What do we care about? We care about the function. We care, like, someone, maybe they have every list of ACEs. Maybe they have all of this trauma, all of these experiences that you can't start to wrap your head around. And it puts our ego first when we want to be like, oh my gosh, this is so big. It's so much. You're so broken. Like, this is not about how someone is broken. And part of a shift to a trauma-informed perspective is recognizing that trauma-informed care is not about what's wrong with you, but it's what happened to you. And so we care about the functional impact of something. We can attend to how is that impacting your daily life, and how can we address those things. I have a fantastic case example that just happened in the last few months that I love to use. I was consulted on a patient on our medicine service who was inpatient in the hospital, and he's like this 60-ish, like later in life man. He's kind of a farm boy. He's real rural, and he's coming in because he has cyclical vomiting because he's such a heavy marijuana user. Now, for context, in Oklahoma, we have medical marijuana, and what you hear a lot is that we have the most liberal medical marijuana rules that they are. Like, you can buy huge quantities, you can grow your own, like, it just is all but legal for any properties. So, but this guy is, like I said, a 60-year-old farm boy, very rural, active in his church, is maybe not like who I would picture as someone who's such a heavy pot user that he's having cyclical vomiting. And so the team starts to meet with him, and they start to talk about the function of his using marijuana, because I've trained them so well. And what they discover is this guy is vibrating at the highest levels of anxiety. He's so anxious all the time. And this was his form of self-medicating. So they say, can you come chat with him? Can you come talk to him about some other strategies for anxiety? Maybe refer him to outpatient treatment, because he wants outpatient treatment. That's something he's interested in. So I go over to the hospital to talk to him, and I just introduce myself, and I summarize essentially what the team told me, that you're having all this vomiting and you were using marijuana to cope, but now you can't. And so I'm here to chat about how we might fill that gap. And he goes, when I was 8 years old, and just immediately launches into this trauma history of a major family stressor that had happened when he was a child that he didn't have the tools to cope with, and the ways that that anxiety has carried through his life. And I was able to do this in the moment education for him and his wife about, this will shock no one, I need to look back and see what episode it is that I went way on this soapbox about dysregulation and autonomic nervous system and trauma response. But I was able to do some discussing with them about what happens when your body is so dysregulated, when you're carrying that trauma with you, and what it can look like how he's feeling that in his body, and how maybe some ways to think about re-regulation, and then how to incorporate that with his larger beliefs about his faith and his spirituality and his community. And it was 30 minutes because he was real chatty. So it was it was a little longer, and he's in the hospital. They're not going anywhere. We got time. But it was such a powerful illustration to me of how something that on the surface looks like, pot use or substance misuse or anxiety, even when you peel back those layers, you go straight to the trauma. And I didn't even have to peel the layers. He just offered it up on a platter to me. But it wasn't about going back and healing the trauma necessarily in that moment. We didn't dig open. I didn't ask for the details about how he found out about this family thing and what he feels and how it recurs. But it was about that function of how it presents and how we can work on re-regulating. And I think that's one of my favorite case examples of what it can look like on a primary care service. In this case, it was in the hospital, but it's still the family medicine team that's taking care of him.
So good. Good.
Yeah.
Do you guys have other examples or thoughts about how it's come up for you clinically?
Yeah, I think I would say, just to add on to that, I think what's helpful for me, and what I think would be helpful to physicians out there listening, is that most of working through trauma is, first of all, working through trauma. It's not eradicating trauma. It's not certainly eradicating memories of trauma. We, as human beings, we can't forget. We're not going to forget. What we're going to do is work through grief, work through suffering. We're going to learn how to sit with negative emotions, and we're going to learn to get in touch with our resiliency. And so when we talk about the power of just safe listening spaces, all we're doing is activating that. We're activating the ability to sit with negative emotions. And when you're sitting there across a person, even just for just a few minutes, I mean, you could do this as a physician, you could do this easily in 7 minutes, sometimes sitting with a patient, giving them some space to listen. You are essentially sitting there while they are talking about very painful things in a safe environment, showing care and love, and showing them that they can face these very hard feelings and these very hard memories, that they don't have to do it alone, and that they can do it. They won't fall apart. And you're giving them that experience of that. So even if all you do is just nice, safe listening, fantastic. And then
again, I'm going to put air quotes around all you do, because
right.
that is the treatment.
That's right. That's right. That's right. And then I think the nuance that we add sometimes as clinicians that I think physicians can learn as well, I think, is listening and then being able to shift with a simple reframe, shift from that stance of feeling disempowered by the trauma to feeling empowered through your resiliency. And a lot of that is simple stuff where you're just noticing a person's strengths. You're just noticing them. You're just being observant about them. And to go back to Bridget's favorite topic, the contextual interview, when you're curious about an individual, you'll notice right away. I mean, it'll just come out. My goodness, you're just telling me all this stuff, and yet you're a great mom. And you have held it together at this job and have this this thing you do in the community that's so helpful for people in the community, whatever it is, you just start noticing like, oh my goodness. Yeah, we can sit here and definitely, hold space for all this trauma and how it's impacted your life, but we can also equally hold space for you and how strong you are. And when you're able to do that with an individual, it begins to shift their perspective. It unmoors them from a sense of hopelessness and anchoredness in the trauma to a place where they are feeling like, hey, wait a second, I actually already have some experience under my belt of having overcome parts of this trauma, right? Because there's no way I could be a mom and be as good a mom as I am without having done something right? I've done something right? And so that simple piece is just one of the things that I think a lot of good physicians tend to do sometimes naturally. I think they must, because by the time sometimes the patients come to me, I'll have the patient tell me like, oh, I just love Dr. So-and-so. She's so nice. She's like, and there's a sense of such deep appreciation. Well, yeah, that person has already created that safe space and provided that care that is, trauma care.
I see Bridget dropping some more quick tips in the chat, and I think we should maybe talk about like, what does it look like? What are some of those more of those like clinical pearls that people can immediately put into action?
I think the way that Neftali just explained it would be my number one recommendation is kind of doing a quick summary. And I think, again, and Jen, since I know you a little bit more, I could see you doing this with patients, and I'm assuming you have a really easy, natural way with your patients of being able to be like, holy shit. What do you?
That's a lot.
That's a lot right there. And yet, we can use humor in these situations if again, you have deep connection,
right,
and it makes sense for the patient, it makes sense for your authentic self, and knowing Jen, so it makes it easier to say. But I can see you just saying that and being like, you went through all of that, and yet you're doing X, Y, and Z the way Neftali said. So you say the quick summary, you have some type of validation of like, dang, that's like a lot. That's a lot. And yet, boom, fill in the strengths. It's a really nice, pithy,
I love that.
Way to remember it, because there's only 3 steps. It's like, be there with them, tracking it, a quick little mini, like summary might freak people out, just like a comment of like, so you went through X, Y, and Z, dang, that's a lot. And yet you're still doing X, Y, and Z. I'm impressed. I think that if you are adding on to your skill set, maybe you're a physician who's been doing this for a while, or maybe you're a BHC, because Neftali, a lot of our BHCs, they don't know how to do this. So what you're just saying that you're a physician, so we're trying to teach our BHCs, our newbies, how to do this. But if you want to go like get a little extra credit, you can start anticipating what a lot of people say. And you could say something like, I can only imagine that maybe based on what you told me, your brain might walk through how you could have stopped it, all the things that you would do now, back from when that happened to you when you were 8. And you'll see their eyes. They're like, how did you know? And it's like, I know, because this is a very common experience that we'll use our current adult brain to literally replay in time. And because we can time travel with our brains, we can think to the future, we can remember the past, which is a really great skill, but sometimes it turns in on itself. And so you're replaying the past, but with your current mind. And for some reason, the way our brains work, it gets the wires crossed, and we keep thinking we can change it. And I just want you to know that that's normal. It is normal to use your 32-year-old brain to evaluate what happened when you were 8 years old. And it is painful and crushing. And it kind of gives you this hope that like, maybe I can undo it, but really at the end of the day, you can't. And I found that people will be in tears. Like, how did you know? I've been dealing with that same process. I've been replaying, and we don't even necessarily do anything about it. I say, listen, this is just what brains do. This is what humans do, and it's normal. And if you catch your brain doing it, be nice to your brain and just remind yourself that you weren't 32, you were 8, and that's it. Your brain will still probably chat at you, but this is a process, and that alone is it's an acceptance exercise. It's an openness acceptance, openness, cognitive fusion. You go through the entire act hexaplex in that one little thing. And that literally can take like 3 minutes.
And if you add to that, or another alternative that I think some physicians do really well is the other nuance is connecting in the somatic experience. So particularly if the presenting complaint is a physical complaint, right? At the end of that sequence, when you're doing listening, and yet you're doing this thing, and you can say, well, it makes total sense to me that you would come in with these chronic headaches. Because you've been carrying this memory, and using Bridget's thing, you can say your brain is working overtime trying to replay this thing and trying to come up with a different ending. And that, you just think about a computer overheating. I mean, I can understand why your brain your head would feel so tense, right? And so when you start kind of making those connections for someone, and then hopefully then connecting back to the resilience, right? And saying, well, your brain's just giving you a signal, right? That it wants some rest. It can't keep replaying this over and over again because it's exhausting to do that, right? And that's when you can say, I wonder if there's some ways we can have you begin to like find that rest, right? And that might be a handoff to a BHC or to Michael, your care manager, to kind of do a little bit more in-depth work on that. But if you're able to just make that simple connection to the physical experience for the patient, then you've hit the trifecta, because at that point, they really feel like, that thing that I came in here for, I understand it. I got a handle on it. I may not even have a solution for it, but I feel like I've got a sense of direction around it now. And we know that from the common factors research, if you just instill that sense of hope, a lot of times patients can actually take it themselves from that point forward. And all of a sudden you will start seeing patients come up with their own solutions, say, I need to get back to exercising because I think that's going to help my headaches. Like it's just like magical. You unleash their anchoredness to the trauma, you inspire a little bit of hope, and then all of a sudden creativity comes out of that, right?
It is a lot, of giving these bits of information about, yeah, that makes total sense. And I think a lot of times where I find a foothold with patients, and I love that we're giving different examples of the language that we use and the way that we connect to patients around this, because it's going to be different for different people, and like what you feel like you gravitate towards, and like, please use all of our language, whatever works for you. But I think where I find a foothold a lot of times is by, naming to people that when you've been through what you went through in your past, your body learns to survive. And the things that your brain and your body use to survive are not always the same way that your body needs to thrive. You end up in you get stuck in this survival mode. And a lot of times you like, look at how you're functioning, look at how you are rocking along at this level. And so of course, sometimes you're going to have a short temper with your spouse, or not be able to sleep, or, feel like you can't quite get your mind around your day-to-day tasks, because all of your energy is going towards this surviving. And if we think about your distress, or, your reaction to this on a scale from 1 to 10, a lot of people don't notice, because you've functioned so well at such a high level for a long time. It takes your body sounding every alarm to get your attention. And so one of the things that can be helpful that you didn't learn, because, and a lot of times this is, when people are talking about like past trauma relationships or difficult childhood, I'll use this, you didn't learn this for whatever reason, is that you can recognize those things sooner. So like you can start to become more attuned to your stress and distress before your body is sounding every single alarm. And so like, what does it look like? Where are you feeling it in your body? We have a little discussion about, that somatic experiencing. And we talk about the fact that most people, and what it sounds like they're describing, is that they're going to get like a level 8 or a level 9 of their distress before they're attending to it. And so I teach a grounding technique because when you're at that level of distress, a lot of times all you can do is like put your hands on your heart and breathe and feel your feet on the floor and tell yourself that you're safe. And then as they start to notice it sooner, then we can do more active engagement about regulation. I made a handout. Oh gosh, I have a copy of it. Made for the residents. And then I started using it with patients too. And so this is a lot more than what happens in like a single discussion of integrated care, like a single encounter. And I'll link to it on our show notes. I have it hosted online, but it talks about like phases of dysregulation. So your body's stress, and there's shutdown state, and there's like your flow state where you're doing well, and then there's this like hyper aroused state. But then the meat of the handout, and what's really beautiful, is all of this idea of like regulation strategies if you can match to what state that you're in. And so this is a lot of information, and it may or may not be helpful in the moment with patients that are in that shutdown state. But when I think about integrated care, and when I think about what I have new learners again. So I've got brand new behavioral health students that are in clinic for the first time, and it's so exciting. And one of the things that I always tell them is, we're not, the thing about primary care and the thing about integrated care is we have such a great opportunity. Like, this isn't one and done. This isn't that we have to get everything fixed for this person, because they're going to be back. Because they're going to need more metformin, and they're going to need more of whatever. So they're going to be back to see their doctor in another 3-4 weeks. And so you're not building a castle in this encounter, you're laying a brick. And so when I think about this, maybe in one encounter, we're raising someone's awareness of where they're feeling in their body. And then in the next time our team sees them, we're building on that grounding technique that we taught them before and teaching them more an active stress management technique and giving a little bit more trauma, connection and psychoeducation. And then the next time we're talking about how they're noticing it in their relationships. And all of this, like, there's all of these facets, none of them are wrong, but we get to see someone repeated over time as they're here to see their physician. It's just such a beautiful part of what we do. And we don't have to feel the pressure of, I've got to solve all this right now, because something that you said that really, I think is impactful early, Bridget, is that this trauma happened to them how many years ago? They've been carrying it around all of this time. It's not that we're going to flip it upside down and solve it in a session. If our goal is to fix their trauma, we are very misguided. So anyway, I think that we have given a lot of good material, and we are like already over, and we have a special segment. So I wonder if anybody has any closing thoughts. There's a lot of awesome things popping up in our chat that are going to go into our show notes. So there's so many more resources. I can't believe we haven't talked about this until now, but any final thoughts from anyone?
I know we got to go.
Yeah, you go, Bridget. You go.
I just think that we help folks to know that they make sense. If they make sense, it's going to get you a really long way. That's all.
Yes. Yeah. And I just want to say thank you, because as the medical person, that's why I love this podcast. I learn something every time, whether I'm participating in it or listening in my car on the way to work, as I have for 3 years or whatever. There's always something great to take away. And that's fulfilling for me. That's exciting. I literally can go take this knowledge. I have a patient literally getting roomed right now, and I can go use this today. I mean, that's the sweet stuff, right? Woo! And I will. So thank you.
Okay, so we are going to shift now to our special segment, as Neftali prompted in the news and notes. There are some really exciting things happening in Pennsylvania, and I had a conversation with Natalie Lefkovich that we are going to share as our special segment. Thank you, Natalie. And now we're going to go to our closing with Deepu. Thank you, Deepu. Thank you, Jen and Bridget and Neftali, for being here. Thank you, Kevin, for doing our editing. Thank you to all of our listeners for joining us, and we'll talk to you again next month.